Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Mudge here. Welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. Hope you enjoy this talk, and if you do, don't forget to check out topmedtalk.com and make sure you subscribe to us on social media as well. More details about that to follow. Before that, let's enjoy this talk.
Thank you, Hannah. Okay, next up we have Professor Alison Mudge, who's going to talk to us about the physician's perspective. Alison has an interest in the older patient, also evaluating surgical co-management services, and also has an interest in delirium. Thank you, Alison.
Thanks, Jeremy. Thanks very much. So I'm calling myself one physician's perspective rather than the physician's perspective, because I think one of the really interesting things about the approaches this afternoon, even amongst the speakers, but also in the group that I'm very fortunate to be part of that Jeremy has convened that's talking about the perioperative journey, is that we all have really different perspectives. We all think we know exactly what perioperative medicine is, but if you talk to a physician or a geriatrician or an anaesthetist or a surgeon, they'll all have quite a different picture, and it's a little bit like the story of the blind men and the elephant that I'm sure you're all familiar with the blind men who will feel different parts of the elephant, and one thinks that it's obviously a tree because they're feeling their leg, and one thinks it's obviously a snake because they're feeling the trunk. So I think that we all bring different perspectives. So my perspective, I'm a general physician. I'm not going to talk about the perioperative patients I manage because I don't. I'm not practicing in perioperative medicine currently, but I'm really interested in systems of care, and I've been very involved in setting up a perioperative service for vascular surgical patients, which I'll talk about some of the practicalities of, but I'm going to talk about them very much from the perspective of being a health service changer and improver and researcher, so slightly different perspective that's going to really complement some of the stuff that Hannah's been talking about. And I think when we're sort of starting to grapple with a problem, we need to really have a good understanding of the problem. And one thing, I work quite a lot in the knowledge translation space, and one of the things that we really know about all healthcare professionals is that we're really good at solutions. We're really good at knowing exactly what's going to fix the problem without always really thinking through what the problem is that we're trying to grapple with. So if we're thinking about the problem of perioperative medicine, well, there's a lot of operations and there's a lot of people having operations, and some of those people get sick. We know that, in fact, anaesthetic care is extraordinarily good and extraordinarily safe nowadays, so that we know that patients mostly get through the operation. That's already been alluded to earlier today. But we know from the audits of mortality, of surgical mortality, that the poor outcomes are mostly in our older, sicker, more comorbid patients. This is not news, but it's a really important fact. And so from a physician's point of view, it's kind of intuitive to think, well, I can get in there. What I'm really good at doing is getting in and really thinking holistically about people who have multimorbidity, and often people who are older, and really being able to get all their chronic diseases a lot better, and I'll be able to really optimise people for clinic. And most of my physician colleagues who become interested in perioperative medicine always start with that. How can I contribute to that journey we've already talked about with preoperative medicine? And I actually think this is probably the wrong thing to do. And I think that there's actually some evidence that this is the wrong thing to do. So I'm sure Katie Gibbs is here somewhere, and she was involved in a lovely systematic review that looked at whether we add value, and with all the caveats that we've talked about interpreting evidence and a lack of evidence, because there aren't very many studies, but there were several trials. which really showed that internal medicine physicians weren't adding a lot. Now, I'm not talking about the no-brainer of someone who's got a very complex, who's had a liver transplant. Of course you're going to involve the liver transplant physician in discussing what to do. Someone who's got terribly complex cardiac disease, of course you're going to have their specialist physician involved. I'm not talking about those no-brainers. What I'm talking about is it really worth our time going and sitting in clinic and helping to optimise when there's actually already a lot of that activity happening? And I would argue that perhaps that's not our best source of value. And there are a few reasons for this. Firstly, if we look back at that RACS data, nearly all of the mortality is in emergency patients, all right? So nearly all of the mortality, so only 10% of the mortality was in elective patients. So we could keep putting more and more resource and more clever people and time into trying to optimise people, but in fact we'd be taking resource away from the group that perhaps have the worst outcomes, which is emergency presentations, urgent presentations, and indeed non-operative cases. So non-operative surgical patients often have poor outcomes, and they're a group that are completely underrepresented in the literature and in fact often have really complex medical needs. So we need to make sure we're not creating systems that actually move resources away from those patients. We also know that complications do occur reasonably commonly. There's been a lot of focus on single organ complications. So we want to think about what heart attacks and respiratory failure, and all because they're bad outcomes. But in fact, they're relatively uncommon. This is a beautiful study, the SAGES study, so Gleason's paper published a couple of years ago, that shows that in fact these are only Clavien-Dindo 2 and above complications. And you can see overall, a total number of 8%. So this was older patients over 70, having elective surgery. And complication rates are certainly much higher in emergency surgery. But the big complication was delirium. So outstripping all of those others 3-1. Now, we've ignored delirium for a long time because we're actually really bad at calling it, at diagnosing it, and so it's been invisible. And we've kind of gone, well, it's not surprising, they're old, they got confused afterwards. But it is the biggest complication, and it's got really good evidence around prevention compared to a lot of these other complications, that in fact the evidence about optimisation and preventing these complications is actually remaining fairly weak. So we know that 30% or more of post-operative delirium can be prevented by some fairly straightforward strategies. And so in this systematic review, in both surgical and medical patients, so these are the surgical studies preventing delirium, there are a number of quite straightforward strategies that we know can reduce delirium, and these have already been, some of them have been touched on already. So these are early and adequate nutrition, early mobility. We haven't talked about activities for social and mental engagement, so keeping your mind active is actually an important strategy, and then pain management and sleep management. And these are really common to all effective delirium prevention programs, but we've already talked about how they can be really hard things to do. Now, they're starting to sound very much like the post-operative components of ERAS. So they've already been kind of brought up in ERAS. And this comes back to my elephant analogies, that we're all often talking about the same things, but we are using slightly different language from our different schools. Now, the problem with the post-operative elements of ERAS, and if you are an emergency presentation, then they're really the ones that are going to affect your outcome, is that even overall, it's the post-op bits that are the most important for determining your outcome. So we can get everything else right, but if we don't get those post-op elements right, we're unlikely to have good benefits. But they're also the ones with the lowest compliance, and they're the ones with the earliest drift. So there is now buckets of evidence about places that effectively implement their ERAS protocol, and then it drops off fairly quickly after that initial resource in implementation. It sort of dries up a little bit, and it's the post-op ones that drop first. So these complex, these simple strategies that are actually complex to do in practice are really the things that we need to be thinking about. And I agree that measurement is really important, but I'm going to bring things back to a really micro level of thinking at a ward level how you might try to get some of these things done. And so I'm going to talk about a study that we've had published this year, finally, after a long time, that is a modest pre-post study in a vascular surgical ward. Because vascular surgical patients are another very high-risk group. There's been a lot done in orthopaedics, but a lot less done in other vulnerable groups. About half of our vascular surgical case mix is urgent or emergent. So they're a very, and obviously high burden of comorbidity in terms of cardiac disease, pulmonary disease, end-stage renal failure. So we were interested in trying to create a system-level intervention, and we were interested in introducing physician management on the ward for these patients, so not a pre-op clinic, but what are we going to do with their management on the ward, combined with a specific delirium prevention program. So I had developed and implemented a delirium program on a medical ward, and our vascular team were very interested, and we had a fantastic director of vascular surgery and professor of vascular surgery who was really keen at looking at this model. The lead clinician on the ward did have some concerns. So his concerns were that he didn't want it to become the orthopaedic model, that he wanted the surgeons to retain control of the patients, that they felt that they didn't want their registrars de-skilling by having a medical team running. And he was really not terribly keen on a co-management model. He was happy to begin with some proactive consultation. And he was very firm about what things the physicians were allowed to touch and not touch. So we were not allowed to touch wounds or antibiotics, for instance. So there was a lot of negotiation. In fact, we had many months of negotiation about what this model would look like. That was informal negotiation, but really that beginning team building. And I think, I can't emphasise how important that initial team building and sorting out what the initial boundaries are. The other thing is he would never have time to come on a combined round. That was a ridiculous thing to think about. Until about 6 months down the track when two of his junior colleagues began rounding with my physician colleague who actually does the work in this service. I just talk about it. And then suddenly the director's like, so where's my ward round? And so over time, so these things take a lot of time to evolve. They were a unit that were really proud that they had a weekly discharge planning meeting, which the doctors didn't go to, but the social workers and the nurses did weekly discharge planning. Now, coming from a general medical background with daily multidisciplinary team meetings about discharge planning, this was almost inconceivable. But you're not going to say, well, that's hopeless, you're going to need to change that. It's this very careful negotiation about would it be possible for us to have a daily huddle between the physio and the doctor and the nurse as a starting point, and gradual iterative improvement. So that co-management model did take quite a lot of negotiation and has certainly evolved quite a lot over time. But the primary focus is on the older patient with multiple comorbidities, and it's driven partly by the surgical team but also partly by the medical registrar. We were able to put in a half-time senior registrar, an advanced trainee in general medicine, as well as a little bit of physician time, and we're able to do that within existing resources, luckily. And we also got a grant for an additional allied health assistant, which is an important part of our Eat, Walk, Engage model. Now, very briefly, our Eat, Walk, Engage model is a facilitated model. We have in this case, it was my physiotherapist colleague and myself, really, who worked as the facilitators, and we worked with the multidisciplinary team to not just to think in sort of not just to say we need to get everybody walking on day one, but to think about what mobility was like, about what were the barriers and enablers, and gradually knock those down. So this is where really thinking at the micro level. It's all very well to say people need to be mobilising it on day one, but if there's nowhere to walk to, if there's no physios on the weekend, if there's no, there are a whole bunch of barriers that you need to think through carefully, and that the team really has to take ownership of solving. So the facilitator works slowly with a multidisciplinary team that meets, like Hannah was talking about, these are not the clinical team meetings, but quality improvement meetings, which we run once a month with the multidis team, and really try and work through those barriers. What's happening at meal times, doing some really structured measurement, micro measurement. How many people are sitting up for lunch? How many people get assistance within 10 minutes? How much time is spent mobilising on the ward? How many people are ever seen over the course of the day to be up and mobile? So really using small level data to inform improvement rather than those larger level quality improvement mechanisms. So that's what the model kind of looked like. Very briefly, we were able to show process improvement. So we had a lot of mealtime interruptions. That was partly around breakfast timing of rounds. That took a lot of negotiation about how we would solve that, but we were able to reduce mealtime interruptions. This is data from activity mapping, where you go round and round the ward looking at people's level of mobility, and we were able to show that we went from only about 1 in 3 of the patients ever being seen to be up and mobile to over 80%. Now, this is amputees. This is a vascular ward. It's quite hard work to get people up and walking, so this is quite dramatic improvement. And then a whole lot of small environmental modifications. So like I said, nowhere to walk is a reason that patients don't walk on a ward. So making a small corner with a jigsaw puzzle and some reading material. Sound like tiny strategies, but adding up, they become very important. The negotiation for that reading corner took several months because the nurse unit manager liked that to be the place where the blood pressure cuffs lived. Looking out the only window on the ward, right? And so we went into battle about this for a long time, and it was really only when she went on 2 weeks leave. And one of the other nurses said, now's the time. And we could have this set up by the time she got home, nice little goldfish bowl, and that corner has stayed. So these are, really small scale negotiations that you might have to do on a team, and that I think a physician is really well positioned to do. So what actually happened? Well, we see about half of the patients on the ward. So this is registrar and physician reviews. We made physician reviews much more timely by having a registrar on the ward every day, half a day every day, by having the physician accessible all the time. So that's not surprising. Put a bit more resource in, get a bit more reviews, doesn't really matter. What we're interested in was did it change other reviews? Now, the remarkable thing here is that 40% of patients were getting reviewed by other physicians. This is cardiologists, renal physicians, lots of end-stage renal failure and renal replacement therapy, other physician colleagues, as well as geriatrics, specialty nursing like our heart failure nurses, those sort of things. So a lot of busyness for these patients. They're complicated patients. And we sort of thought that if we were seeing them, other people wouldn't have to, and that wasn't the case at all. Very disappointing. But when we looked at the numbers, in fact, what we were doing was a really good job of coordinating. So people were still seeing the nephrologist when they had end-stage renal failure, but the nephrologist didn't have to come back every day to make sure that the junior staff were doing the right thing because there was someone who was coordinating. So significant reduction in the frequency of I'll skip through, of both medical and allied health reviews because of team coordination. So with all of these things, we did a pre-post trial where we were able to measure some patient outcomes. Delirium and functional decline were what we were really interested in, and they were reduced by about a third. We're not talking about p-values this afternoon at all, obviously. So small study, pre-post trial, some differences, but differences, the kind of differences the literature should be telling us. So quality improvement project, and in our emergency subgroup, a very dramatic reduction. So you can see beforehand a third of patients with delirium and functional decline, and that was reduced in our very much by the intervention. And at system level, so if we compare the data, our administrative data for people aged over 65, the year before and the year after this was implemented, we had a 0.8 day reduction in our median length of stay, more than 20% higher rate of going home rather than to subacute care, so very important outcome for patients. And a small but non-significant reduction in mortality, because mortality is pretty low in this group anyway, because it's an excellent centre. So system-level outcomes that are reflecting the patient-level outcomes shown in the trial. So in summary, I think this is the kind of model for the way that physicians can really add value, because in fact as a general physician, rather than sitting and seeing several high-risk patients who are already being seen under really well-structured processes by good anaesthetists, I think that we can really bring that conducting the ward, and I think Hannah's already talked about that in orthogeriatrics, so that being able to comprehensively assess the patients. I haven't talked about the medical care, all the usual stuff, how bad are their fluids, what's happening with their heart failure, all the day-to-day stuff, what's their hyponatremia. We're not, we're good at doing that. We can just get on and help the junior staff with doing that on the wards. But coordinating the teams, making sure there's good coordination, staying focused on discharge, teaching the junior staff who are often abandoned on the wards during the daytime when the surgeons are in theatre, and really helping to contribute to these small cycles of meaningful ward quality improvement are really within the skill set of the general physician, and I think particularly should be focused on the wards that have these high-risk patients that really don't have all that lovely time for optimisation because they just end up through emergency department on a trolley in theatre, and whose outcomes we know are really poor. Thanks.
Top Med Talk. It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.